Bismillah ar-Rahman ar-Rahim. The ankle actually is one of the simplest joints in my opinion. This is the most simple one. Yes. You will see it that is a very simple joint compared to the knee and to the shoulder. The ankle is very simple in approach and in diagnosis. There are few lesions around the ankle and you can easily manage in a simple way as I'll show you to you. Then you remember these machines, and this open magnet is suitable for examination of the ankle, and this is the coil we use, and it is used for fixation of the foot, and you can also fix the foot with some sponge here. These are the protocol for examination of the ankle joint. What is the most important issue in all of these is the field of view, and this is the major problem we have. Usually the operator do not stick for the small field of view, because it makes the examination lengthy. And they want to finish up with the patient quickly, then they increase the field of view. Then the anatomy will be very small and you cannot identify any of the anatomical landmarks. Then the usual field of view for the ankle ranges from 8 to 12 centimeter. This is the optimal field of view, and if you are in a charge, you should insist for this in order to get some images that you can interpret. Then what do you think about these examination planes for the ankle? Which is the most suitable? And you see in the knee, the most suitable plane of examination is the sagittal. In the shoulder, you see some go with the axial and some go with the coronal sections. They are very important. But in this ankle in particular, the axial images are very important. The axial images are important. Then how to know the pulse sequence? When the bone marrow is bright, this is T1, less bright, this is T2, more dark, this is gradient, very dark, and this is the stair images. And also you remember this rule: the non-mobile protons, including the cortical bone, the ligaments, I'll see the ligaments, then the tendons, the calcium, all of these appear black in the T1 and T2 weighted images. The fluids appear black in the T1 and bright in the T2, like the fluids around the tendon sheaths, for example, synovial effusion. Then the fat, which is the reverse of the fluid, the fat appears bright in the T1 weighted image and less bright or dark in the T2 weighted images. Then this is the policy how to deal with the ankle. The policy how to deal with the shoulder is you identify the anatomy. You see, and I would like to see tendons, I would like to see ligaments, bones, bursa. This is not the rule for the ankle. The best rule for the ankle is you divide the ankle into 4 components or compartments: the anterior compartment, the posterior, the medial, and the lateral. Then each of these compartments has tendons and ligaments. Each of these compartments have tendons and ligaments. But the posterior and the anterior compartments contain tendons only. There is no ligaments, unless there is no ligaments anterior and posterior, but the ligaments are located medial and lateral. Then you remember the posterior compartment contains tendons, the anterior compartment contains tendons, but the medial and lateral compartments contains tendons and ligaments. Then we start the evaluation of the posterior compartment, and in the posterior compartment there is only one tendon. There is no ligaments, and this is the Achilles tendon. Okay. Then this is the simplest way to assess the ankle. You start by the posterior compartment, assess the Achilles tendon, then you go to anterior compartment, medial and lateral. Okay. In the posterior compartment, you see the Achilles tendon, which is black in the T1 and black in the T2. This is the strongest tendon all over the body, but it is frequently injured because of its superficial location. And you can see here, this is the tendon, which is black in all pulse sequences. And you can imagine that the axial images are the best for evaluation of the Achilles tendon. The axial images are the best for evaluation of the Achilles tendon. And here you can see the tendon is intact, but you should go to the axial images and to realize this appearance. The anterior part of the tendon should be flat or concave. If the anterior part of the tendon is convex, you are dealing with an abnormal tendon, in spite of the signal. Then if you see the tendon like this is an intact tendon. Uniform signal, flat anterior surface, convex posterior surface. Then the rupture of the Achilles tendon is easily identified, in the sagittal and in the axial images as well. When the tendon rupture, you should say these facts. Where is the site of the rupture in reference to the insertion site in the calcaneus? The distance between the cut edge and the insertion site in the calcaneus. Number 2, the gap between the cut edges. Like the supraspinatus, you should specify for the surgeon the gap between the cut edges of the tendon. Then you should say, or you may not say, what is inside the gap, fat or fluid or blood or both. These are the important items to be fulfilled with rupture of the Achilles tendon. Then here you can see this is the rupture of the Achilles tendon, and the tendon is corrugated, and this rupture had been repaired before and re-ruptured once again. And if you go to the axial images, you see the normal tendon on the left side and the abnormal tendon on the right side. You see abnormal signal and you see abnormal configuration. Another case of rupture of the Achilles tendon, and you see the tendon is markedly swollen, and there is a gap starting in between these two arrows, and the gap is filled with something which is bright in the T2 and black in the T2, this is fluid, and something which is bright in the T1 and black in the T2, which is fat. Then you know that this rupture extends from this distance, and it is away from the insertion site by about 1.5 centimeter, for example, and the gap is filled with fat and fluid. Then if there is a partial tear, you should go to the axial to assess. You see here, this is the normal tendon, and in this area you can see the tendon is swollen, and there is a bright signal in the T1 and a bright signal in the T2, meaning that there is blood in the site of the rupture. Then the tendon, being thick and strong, can be partially torn. Then if you see here, you see some fibers that are intact, some fibers are torn, and you see fluid in the site of the tear. Also here you can see this is the Achilles tendon, and you see this very bright signal which is specify rupture or partial rupture of the tendon fibers. Then if you look to the Achilles tendon, you should know that the Achilles tendon has no synovial sheath. There is no tenosynovitis of the Achilles tendon, but there is tendonitis and tendon degeneration and peritendinitis. There is no tenosynovitis. Then if you look to the Achilles tendon and you see that the tendon is swollen and there is an intermediate signal like the signal of the supraspinatus, then you are dealing with degeneration of the Achilles tendon. In this area, you can diagnose tendonitis without the presence of calcium in the Achilles tendon, but in the supraspinatus tendon, no. Then look at this tendon. You see the tendon is swollen and you cannot see any abnormal signal inside. This tendon is relatively swollen and you see a very bright signal. This is tear. This is partial tear. But intermediate signal or no signal but a change in the caliber of the tendon are diagnosed as Achilles tendonitis. Then this is the difference between tendon degeneration or tendonitis of the Achilles tendon and the tear. You see the tendon is swollen and there is bright fluid signal inside the tendon denoting partial tear, and this is tendon degeneration or tendonitis of the Achilles tendon. Then you know that there is a small bursa between the insertion site of the Achilles tendon and the posterior aspect of the calcaneus, and this bursa is normally filled by minimal fluid. Then this is the site of the bursa in the axial images, and this is the site of the bursa in the sagittal images. And if you look here, this is inflammation of the bursa. You got more fluid in the bursa, black in the T1, bright in the T2, and you see the amount of fluid in the bursa is enlarged. Then you got what we call retrocalcanean bursitis. This is a case of rheumatoid arthritis with retrocalcanean bursitis, very common association. And you see that the bursa is filled of fluid, it is enlarged, and the fluid is very bright signal in the T2 weighted image. This finishes the first compartment, which is an easy compartment. Then you go to the lateral aspect. In the lateral aspect, you have ligaments and tendons. In the lateral aspect, you have ligaments and tendons. First, how to identify the lateral aspect? By the presence of the fibula. Then, this is the axial image of the ankle, and you see this is the site of the fibula, and this is the tibia, and this is the talus, and here you see this is the site of the fibula. Then, in the lateral aspect, there are ligaments and the tendons. The tendons on the lateral aspect are the peroneal tendons, which are the peroneus longus and the brevis. Then if you see, this is the fibula, and this is the fibula as well, and you can see two small structures posterior to the fibula, and these are the peroneus longus and the brevis. You see here, this is the peroneus longus and the brevis, and they cross posterior to the tip of the fibula. Then, which is the brevis and which is the longus? The peroneus brevis is anterior and medial. The peroneus brevis is anterior and medial to the longus. And this is very important because the brevis is frequently torn while the longus is not. Then you should identify in the axial where is the brevis, and the brevis is medial and anterior, and the longus is lateral and posterior. Then these are the this is the fibula, and these are the tendons. This is the brevis, which is anterior and medial, and this is the longus. And you remember that the peroneus longus will show the magic angle phenomena, like the supraspinatus. These are the only tendons in the body showing this phenomena, which is the magic angle, and you can see this abnormality in the T1, and you don't see it in the T2 weighted images. And you remember also that there is less frequent injuries of the peroneus longus compared to the peroneus brevis. Then if you look to this ankle region, and you see this is the fibula, and you see two tendons. The anterior one is the brevis. The posterior one is the longus. Then you see here, and in this area, I hope you can see that there is a tendon, only one tendon, and there is an edema or fluids around this tendon, and the second tendon is missing. Then you can say safely that it's the tendon of the peroneus brevis that has been torn. Then sometimes this is also a normal variant in the peroneus brevis and in the biceps tendon. Normal splitting. The tendon may be splitted congenitally. Then you see that there is a peroneus longus and two tendons corresponding to the peroneus brevis. And if you don't have a history of trauma or signs of trauma like bone marrow edema, soft tissue contusions, and fluid signal, and this is a congenital variant. Then what about the ligaments? There are two sets of ligaments on the lateral aspect. The first set is known as the lateral collateral ligament, and the second set is known as the syndesmotic complex. Then we start first by the one which is very important. It is the lateral collateral ligament. The lateral collateral ligament is formed of three components. The syndesmotic complex is also formed of three components. ولكن يعني it's extremely easy. Then how to identify first the lateral collateral ligament? Then you go to the lateral aspect of the ankle, and you identify the fibula, and you look for the fibula for this groove, a medial groove. You see in this area, you see a concavity on the fibula. If you identify this concavity, you are at the level of the lateral collateral ligament, which is formed of these ligaments: the anterior talofibular, the posterior talofibular, and the calcaneofibular. Where is the anterior talofibular? This one. This is the anterior talofibular ligament. Where is the posterior talofibular? It is coming from the groove posteriorly. This is the anterior talofibular, and this is the posterior talofibular. The anterior talofibular is the most constant ligament in the ankle at all. And you should identify this ligament in any examination, whatever bad it is. Then, if you see the fibula, you should identify the groove. Then you see a ligament coming from its anterior aspect. This is the anterior talofibular. And coming from the posterior aspect, this is the posterior talofibular. Because this is very constant and seen in every examination, it stands for the lateral collateral ligament. Whenever you say injury of the lateral collateral ligament, you are meaning that the anterior talofibular ligament is torn. Okay? Then, where is the calcaneofibular? It is not usually seen because it cannot be cut in a single blade. Then you see part of it, and then it is not important in the evaluation. Then the lateral collateral ligament, you see the fibular groove, then you see the posterior talofibular and the anterior talofibular. The same issue, the anterior talofibular and the posterior talofibular. Then if you look to this normal appearance, they see this is the fibular groove, is clearly seen, and this is the anterior talofibular. Where is the posterior talofibular? It can appear in another image, and you should look in the previous or in the coming image. Then if you see this examination and you see this is the fibular groove, and coming out of the fibular groove, the posterior talofibular. If you look for the anterior talofibular, you cannot see, and you can see fluids at the site of the ligament, meaning that this anterior talofibular ligament is torn. Then sometimes this is the normal anterior talofibular, posterior talofibular. Sometimes you look at the anterior talofibular and you find it very, very thick, but then the signal is preserved. And this, you remember, every now and then anyone can sprain his ankle, and this sprain causes some minor injuries in the ligament, and after fixation and less weight bearing, the ligament repairs itself. And by time you got a very swollen tendon but of normal signal, this is known as chronic injury of the lateral collateral ligament or of the anterior talofibular. Then this is an old technique to see the talar tilt angle, and if you tilted the foot like this and you measure the angle between the tibia and the talus, this angle is normally less than 40 degrees, and there is a minimum of 10 degrees or the maximum of 10 degrees variation between both. But if the lateral collateral ligament is torn, then you expect that this angle will be increased. Nowadays, we do not refer for this because of the limitations of pain, the force of the examiner, and the laxity of the normal leg. Then you came to the syndesmotic complex. The syndesmotic complex are ligaments coming from the fibula to the tibia. Then we call them the tibiofibular. Okay. Then the tibiofibular are also three: the anterior, the posterior, and the transverse. Don't bother yourself with the names, but if you imagine the talus in relation to the tibia, the talus is inferior to the tibia. Okay, then you see the lateral collateral ligament or the talofibular ligaments at inferior plane, and when to look to the tibiofibular ligaments at the superior plane. Then if you identified the fibular groove, then you are at the level of the lateral collateral ligament. Then go above by two sections only. Then you see the fibula like this, and you will see a ligament coming from its anterior aspect. This is the anterior tibiofibular, and another one coming from its posterior aspect. This is the posterior tibiofibular. The inner fibers of this posterior tibiofibular is this one, which is the inferior transverse ligament. It is a component of the posterior tibia. Then, if you look here to the site of this fibula, this is the tibia, of course, and this is the medial malleolus, and this is the lateral malleolus. Then, at what level are you now? Is it the fibular groove? No, you are above. Then, this is what? Anterior tibiofibular, and this is what? Posterior tibiofibular. It is clearly seen here. Then, I'll come back to this anatomy once more. Okay, then we go to the anterior aspect where there is only tendons. There is no ligaments in the anterior aspect. And in the anterior aspect, you got the extensor tendons. I'm sorry for this. This is extensor tendons. And you have three muscles: the tibialis anterior, the extensor hallucis, and the extensor digitorum. Then you see these muscles. This is the tibialis anterior, this is the extensor hallucis, and this is the extensor digitorum. If you look posterior to the tibia, you will see also three tendons, which have almost the same names, but the flexors. They are the flexors. Then, the tibialis anterior is intimately related to the tibialis posterior. They are at the same plane. This is the tibialis anterior, and this is the tibialis posterior. Then you reverse the names of these. And instead of this is the extensor hallucis, this is the flexor digitorum. And this is the extensor digitorum, and this is the flexor hallucis. How to remember this in a very simple way? forget about the sentences and the بيت الشعر والكلام ده كله. انسى الموضوع ده. You just remember that the tibialis anterior is related to the tibialis posterior, okay? Then you know that the most largest muscle on the posterior aspect of the ankle is the flexor hallucis. The flexor hallucis. Then you know this is the flexor hallucis, this is the flexor digitorum, and this is the extensor hallucis, and this is the extensor digitorum. That's all. And you know that the tibialis posterior and the anterior are on the same line. Then the largest muscle here is the flexor hallucis, then this is the flexor digitorum, and this is the extensor hallucis, and this is the extensor digitorum. And you remember, this is the Achilles tendon, and this is the peroneal muscles. This is the peroneus brevis, which is medial, and this is the peroneus longus, which is lateral. Then here you can see the muscles. This is the tibialis anterior, وبعدين extensor hallucis, وبعدين extensor digitorum, and the tibialis anterior tendon is swollen with fluid signal and abnormal signal inside. This is traumatic, post-traumatic injury of the tibialis anterior, which is rare. This tendon is relatively rarely injured. Then this is another example. What do you think about this? Is the fibula. At what level are you? The lateral collateral or the syndesmotic? Yes, and this is anterior tibiofibular, and this is posterior tibiofibular, and this is the tibialis anterior, and this is the extensor hallucis, and this is the extensor digitorum. Okay, then you came to the medial aspect where tendons and ligaments are located. We already finished with the tendons, which are the flexor tendons, which are the tibialis posterior, the flexor digitorum, and the flexor hallucis tendon. Then the medial tendon, which is located here, is known as the medial collateral ligament or the deltoid ligament. We start by the tendons because the tibialis posterior is frequently injured, and you have three types of injuries in the tibialis posterior. The three types, type 1 means hypertrophy of the tendon. The tendon is markedly enlarged. Then what is the reference for you? The tibialis posterior is normally twice the size of the flexor digitorum or the flexor hallucis. If it is 4 times or 5 times, then you know that this is type 1 tibialis posterior injury.